Whoa, congratulations. We're really making some progress here. And neck and throat, that's really, really important. But now we're getting into dental, right? You think about mouth and teeth, that's dental, and jaw problems, that's dental. So, and some of this is some of the most obvious part of TMD where we get referrals. So, you know, when people are clicking, we get referrals, grating sounds, referrals, right? Uh, and we get the referrals from dentists who don't know all the signs and symptoms, right? So someone might not know. The dentist says, "Well, I feel like I got something caught in my throat, right? I have something caught. I have a feeling of a foreign object in my throat. I can't clear it." Dentists may not know what that means, but they're going to know jaw problems because that's their area. The most common thing that we see is when the temporomandibular joint disc, which is like a little hat that sits on top of the condyle, it needs to stay in place, some movement, but as you move it around, it stays pretty much in place. As we have damage of the ligaments, which are ropes that hold it, may not have a lot of collagen, that disc starts slipping back and forth, and like a watermelon seed, it pops. And so it almost always goes anterior, but it also goes medial. We don't really talk about that. It's really anterior medial displacement, but for simplicity's sake, we say anterior. Disc means bad, a bad place. Disc with reduction means it goes back into place at some point, right? When you open slightly, it goes back into place. When you bite and press against your ear, it comes off and goes forward. So you got when you open, it clicks back on. When you close, it clicks off. You hear something called a reciprocal click, right? And click, 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 click. And the later it pops, the worse it is. So the later it clicks, the worse it is. But you hear noises in the jaw joint, which you can use a stethoscope, or I very often just like to put my fingers on the right and left jaw joints and have them open and close. And I can feel plus hear this noise, right? Uh, you can also look at the jaw as it's opening because as a click occurs, there's a change in movement of the jaw. Isn't that interesting? And this is more kind of advanced, right? And it takes more thought and more thinking. But you got your anterior displaced disc with reduction. You also have dislocation. This is like, when some people can have their shoulder bone pull their shoulder out of place. Literally, the joint is coming apart. The condyle is inside the mandibular fossa, which is part of the, temporal bone. That condyle could come out completely and go forward over the articular eminence and come forward completely out of joint. And then that's called an open lock. But that is a TMJ condylar dislocation. And they don't have to lock. They can come out and in, out and in, dislocate out of the joint, come back in, dislocate out of the joint, come back in. That can make it makes a very loud noise at the end of the opening phase. So you're closed and you open, 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 then you open in the maximum amount. You hear a huge pop, bang, and the mouth is really open wide when you hear this big pop. And that is TMJ, temporomandibular joint condylar dislocation, and that is not the disc. Besides clicking and popping, there's another joint sound that a patient can make. God did not mean for bone to rub against bone. Bone rubbing against bone will degrade and break down bone, and the hard outer surface of the bone will go away. All right, and we call that osteo means bone, arthro means joint, itis is inflammation. And when something's inflamed, you press on it, it hurts like hell. Now, if you have the same exact thing, breakdown of the bone, dissolving of the bone, but you press mash on the joint and there's no pain, there's no itis in there, we call that osteoarthrosis. Some people just use the same term osteoarthritis even when there's no pain on compression. I'm not sure that that is correct. But the word for that grating noise, that gravel noise, is crepitus. And crepitus is bad. When you hear the crepitus, you know that the bone is breaking down. The outer coating of the bone is breaking down. And the problems associated with that over time are greater. That case has got worse and worse, has progressed onward from, a normal joint to slight clicking to heavy clicking to locking, transient locking to full locking to degradation, right? And typically, too, you will see a calcified stylohyoid ligament on the side of the crepitus. Very common. And Dr. Farah had mentioned this in his book. So pain in the cheek muscles, right? So you mash on the masseter. And the masseter comes forward, right? Down forward to the front of the cheek, below the eye. And so people can confuse that too. So they could say it's sinus pain, or they'll say pain behind underneath the eyes, and it's actually the masseter's anterior attachment on the zygomatic process, or the zygoma bone. But the masseter can be inflamed, overworked. Muscles hurt when they're overworked, right? And we call that myalgia. The inflammation associated inside that muscle is myositis. That's myositis, inflammation. Myalgia is pain. Algia means pain. Itis means inflammation. So two terms for similar things, but not exactly the same. And then we have the zygomaticus muscle myalgia also, right? That's a very common thing that we see in TMD patients, but pain in the cheek muscles. I can talk about this issue over and over and over, and I can talk it over and over. It is craziness, and there are influences. The jaw position influences the brain and influences the spinal cord. I'm going to make a statement. Jaw positioning influences the brain stem, which means jaw positioning can create neurological issues, uncontrollable movements, shaking, hand shaking, body shaking, uh, the movement of the lower jaw shaking. We call this denture dis, means bad kinesis is movement, denture dyskinesis, and we see the person who has a denture that's overclosed, not quite right, the face is smashed low, not really full length, and they're shaking. You watch them, they're just shaking and shaking. That comes from the denture not being full length. So you can imagine if you have pair of pants that are too long and you put them on, it's like nothing fits. Well, the teeth that was made by the dentist, it's too short and they should be longer, and it's jamming their joint, and they get movement problems of their lower jaw. The masticatory muscles start shaking all over the place. You can see it. It's very common. They usually have also a neck problem. You can see the widow's or dowager's hump on these people too. Very common. Tardive dyskinesia is movement problems of the face, unusual grimacing and moving around, making facial things. Very often starts from certain medications. And boy, and I've had two of these, and both of them I've cured. I've been very fortunate. Also work with a neurologist who was brilliant, who thought of me as his co-professional. Interestingly, I haven't had very many referrals recently from him though. But we worked together on two cases, and we cured the patient. And then I believe that as the forward head comes forward and all the muscles contract, it moves the vertebral bones out of place. Wait a minute, what's encased? There's a tunnel in the vertebral bones for the spinal cord. And if the spinal cord gets compressed or squeezed, stenosis means a small hole, smaller than the spinal cord, so you get a compression, you get crazy movements. And they go to the neurologist, and the neurologist gives them a lot of drugs. When in fact, get this, repositioning the jaw may, not always, so don't get me wrong, not always, may cure this problem. Is there any crosstalk between neurology and dentistry? There is not. Uh, I heard a extremely famous migraine physician at a meeting. I went to a International Headache Society meeting, and some researcher from Germany had basically did some interesting research and took half of a head, put in a dye. Dye makes colors, but this dye only dyed nerves. Okay, so basically took half a head, put it in a plastic bag, put this dye in, let it sit for 3 to 6 months, and then went back and did slices with microscopes. And what he found amazingly was that the nerves inside the brain come out through the side of the bone and into the temporalis muscle. Go back and look at the temporalis muscle. They come out and they go into the attachment where the temporalis muscle sticks to the side of the skull. And I went crazy because I'm like, this is amazing. It's one of the most amazing things. And I actually thought about Botox, because what do they do with Botox? They inject this very place with Botox, which affects what? Muscles. And it takes care of migraine. Oh my God, what is migraine? It's the blood vessels in the brain going crazy, but the nerves that go to the blood vessels, in fact, come out and go into the temporalis. So if the temporalis is pissed off, has myositis, myalgia, splinting, it's going to piss off the nerves inside the skull also and cause migraine to get worse in some cases, many cases. This is why very often when we treat TMD, migraine will subside or be eliminated because the triggers for the migraine are being removed. Not to say this is always true, but I'm saying there is a relationship. Got it? And it's just walking problems. I've had one lady came in with a cart. She couldn't walk. And after we started treating her, within like a few months, she was walking by herself with a cane and then eventually by herself with no cane. But that came from my care. Whoa. Can I explain it? I could speculate. Does the neurological community know anything about this? Not at all. Why? No professional crosstalk. It's going to take years before we start working together. And I think that's one of the things about the Atlanta TMD Institute that I hope and pray over time as we grow will in fact address some of these issues of interprofessional crosstalk on various subjects and accumulate some research to share so that we can start better helping people. So guys, you've done well. We've gone through like 7 sections and now we're getting into the last section, which is ear problems. And I am extremely interested in this. However, I get a little depressed because of the inability for me to work with ENTs who sometimes just don't want to listen. They don't want to integrate as professionals, they don't want to learn. I've had one ENT who used to come and visit with me every month or so. We'd have lunch and we'd have just discussions that were wonderful. And it was fantastic. And he would refer me almost like 2, 3, 4 patients a week until one time it stopped. And I asked him, what's going on, Pete? And he goes, the group that I'm in found out that you refer to a chiropractor, and we will not refer anybody to you ever again because you're a chiropractor lover and chiropractors kill patients. I said, Pete, okay, I will just not refer any patients to chiropractors that you refer to me. No, we've already decided to sit down and decided that we're not referring any patients to you because you're a chiropractor lover. And I say, well, Pete, that's crazy. He says, I know, but I'm in a group. I got to go with what the senior physicians say. Isn't that crazy? I mean, I've got stories about ENTs. I mean, I love them and I hate them. It's a terrible relationship. I think if they integrated with us, we would get so many people healthy. But it's just part of, I think, the evolution of this knowledge. It's going to take 50 to 100 years for it to be influenced. And perhaps maybe that will be my role in the next 10, 15 years to try to influence uh, the ENT profession to learn about this stuff. But then I look back at the allergist Meyer Marks, who wrote Stigmata of Respiratory Allergies. He used to lecture all the time to orthodontists, and they just never adopted his ways, even though he clearly showed a lot of the problems that these orthodontists are going to have. They just ignored him, or at least he lectured, they liked listening, but they never adopted and became part of their practice. But we're going into ear problems now. So I am a little excited to talk about this because many TMD patients have hissing, buzzing, or ringing in their ears, even though it's not coming from anything in the world. The ear itself has gone bug crazy. And they call that tinnitus, right? So tinnitus is the term for hearing noises all the time. And it's part of Costin's syndrome, which was an ENT in 1934 who wrote all this stuff up. But yet the ENT profession, which Dr. Costin was an ENT, has not adopted a lot of this information and put it into their treatment and protocol and assessment. But this tinnitus can be from the tensor tympani muscle. The eardrum has a muscle that tightens and loosens the eardrum. So if you're going to hear something loud, the tensor tympani tightens so that the eardrum won't go real crazy on you, and it protects you. But it's a muscle inside the middle ear. Ear infections can cause buzzing, hissing, and the eustachian tube dysfunction can also cause tinnitus. So tinnitus can be caused by a lot of things. And I tell patients I have about a 50% success rate in getting rid of tinnitus. 50%. This is good and bad. So a lot of times I will begin treatment with the patient with the intention of taking care of the TMD and eliminating the tinnitus. But half of the time at the end of the 6 months, I have to look them in the face and say, we tried, and but it didn't work. And they look at me like I just spent $4,400 or whatever it might be, and said, well, I couldn't promise you this. I don't know who's going to treat out well or not. It could be that there's internal damage from years and years and years of the tinnitus, and I can't address that internal damage. All I know is that perhaps when you were younger, when you first started, we probably would have had a better chance. But right now, I try my best. And that's hard for some dentists to deal with, right? But I just have to accept that. You know, when a cancer therapist provides therapy to cancer patients, they don't tell them they're going to all survive. You approach it the best you can with the tools you've got and understand your failure rate and deal with it as best you possibly can. But when it does correct, it's just a wonderful, wonderful thing. And you've influenced their lives tremendously. But we have to start thinking a little differently. This is a good example of where the mentality of the dentist, you know, we're so used to fixing mechanical problems. Like, you know, there's a cavity. So we take the cavity out and we put the tooth back together using composite. Or the tooth is broken down, it's split, and we go back and we put a crown on it that looks just like the original tooth, and it chews just like the original tooth. Everything's fine, right? Or a tooth dies and we go in and do a root canal and take out the guts of the tooth and fill it with a rubber, and that tooth is the same as it was almost before. We're used to correcting things definitively and wonderfully. It's a good profession, isn't it? But medicine doesn't work that way. No doctor goes in and says, I'm going to do this operation. You're going to be fantastic for the rest of your life. So we need to be able to deal with this issue. But we're going to do our best to help our patients, aren't we? So you got a big drum, and you hit that drum hard, and the membrane, right, vibrates up and down. It goes down slow. That is the drum hits, and it creates noise, vibration in the ear. And the eardrum, the sound hits the eardrum, it vibrates, goes through the three little bones, malleus, incus, stapes, and goes into the inner ear to be sensed as sound. But if the eardrum does not vibrate back and forth, boom, it's too tense. Like you take the drum and tie it so tight that it won't vibrate, and you don't get the noise on the drum. It'd be nice to take a drum and practice with that. Just tighten it down so much, and then hit it and won't make noise. It has to vibrate. So the tensor tympani could be tightened, right, from the medial pterygoid muscle being tight, and you won't get vibration of the eardrum, and you get decreased hearing. The malleus might be stuck, right? These bones, these three bones, might actually be stuck, right? They are not moving around. Same thing with the cervical vertebra. They are stuck. They don't move around, and you get neck problems. Well, you can have the malleus be stuck. Unfortunately, we can't get in there and mobilize it. But you could, the same thing with the different three bones, malleus, incus, and the stapes, all connected in a chain. And these little bones are called ossicles, right? So we call it the ossicular chain. And they may not move well, either because of muscle contractions or ligament shortening or damage from infections that were in the middle ear, lots of stuff. It is a common symptom to have ear pain, and there's no infection. So who does the patient go to? Again, boy, this is a TMD symptom. I'm talking about TMD, dental problem, right? Joint problem, dental joint problem. Oh my God. Ear pain. Who do they go to? The ENT, the otorhinolaryngologist. And, yeah, I can't believe it. They don't know what it is. So I just don't know. Everything looks fine. I don't know why you're having pain. Well, pain can come from very often muscle pain referral. We talked about the heart referring pain. And what are these muscles? The deep masseter muscle pain referral, the medial pterygoid muscle pain referral. These go to the ear and cause ear pain. The clavicular division of the sternocleidomastoid muscle pain. Oh my God, I hate the SCM. The lateral pterygoid muscle can refer pain into the ear. And then finally, there is a ligament. All right, we got a disc in the joint, and you're not going to believe this. There is a rope on the back of the disc that goes into the middle ear and hooks on to the malleus. This is the first bone in the ear, in the ossicular chain we talked about. So the malleus can be fixated by the discomallear ligament or the pintos ligament because the joint, the disc, if there's anterior displaced disc and there's a rope on the back of the disc, as the disc goes forward, it tightens the malleus and you get pain in the ear or decreased hearing, right? Very interesting. Just a comment. God thought about the ear after he thought about the jaw. So the malleus and the incus are reptilian jaw bones that have been repurposed by God. So they originally were jaw bones. Then as evolution occurred, they became ear bones, right? And get this, we got the three bones in there, the malleus, incus, and the stapes. The stapes was a fish jawbone. So all three of the ossicles in the ear come from jawbone origins, right? They were first chewing bones, right? And they still have remnants and connections to the jaw. Of course, they come from jawbones, but yet we don't have this connection among the professions. So this cloggy ear thing can come from excessive earwax, and that's pretty common with TMD patients. They have huge plugs of earwax. But you can also get cloggy, itchy ears from the eustachian tube being blocked from allergies and not being able to be opened. The tensor tympani muscle can cause clogged ears. Get this, the tensor villi palatini muscle, this is one that opens up, pulls up when you swallow, pulls the soft palate up and opens the eustachian tube. You can get problems from that. And then, as I said, excessive earwax deposition. That might come from literally the condyle ramming the ear because many patients, their condyle literally goes back, crushes and destroys the retrodiscal tissues, then slams into the bone, and that bone in the back of the joint is the bone in front of the middle ear. So you've got two rooms, right? One room is the bedroom A, bedroom B. The wall between them is the same wall. The middle ear front wall is the back wall of the joint. Got this? Very important. They're adjacent structures. The wall connects the two of them. Very important concept because of their anatomy and their anatomical close location. Continuing with the last ear problem, vertigo and dizziness. And this is crazy butt because every ENT is going to think that it's an inner ear problem. They see the vertigo and they send them in for inner ear therapy. No kidding. Oh my Lord. But the sternocleidomastoid, a clavicular division of the sternocleidomastoid, can cause this dizziness and vertigo. It's crazy, So in your right ear and your left ear, there's a vestibular, apparatus, and it's like a gyroscope so that your eyes are straight to the ground. And when your head moves, it will right your head back so the eyes are correct because it's right outside of the eyes. But there's no gyroscopes in the rest of the body. The rest of the body doesn't know where it is, right? But the head does. So the head has to tell the rest of the body to straighten out. How's it do it? By muscles. So the head straightens out, and then the muscles contract to straighten the rest of the body, and that is done by the sternocleidomastoid muscle. Oh my God. The sternocleidomastoid muscle, that bastard seems to be involved in so many things that we get crazy about the thing. And that's why I'm fixated on that. In my therapy, I look at it. I want that muscle calmed down. I want it calmed down. It refers pain into the ear. It refers pain all over the place, into the throat, the forehead, above the eye, behind the eye. Oh my God, all over the place. And let's get this one calmed down. So another thing is some people do have odo means ear, lith means like a rock. So there's little ear rocks that are kind of messed up and in your ear. And so when you move your head left and right, and these little these will cause also disorientation, vertigo, and dizziness. And this is true inner ear problems causing dizziness. So it could be that you've got an inner ear problem, but I think more probably it's going to be a sternocleidomastoid problem. So let's be clear. The Kidney Fund Stack Index, and Dr. Stack was a mentor of mine. I knew him. He wanted to edit my book. This is the most common symptoms, but there are more symptoms than just the kidney fund stack, right? And there are other comorbid problems, things that are associated with TMD. There's more to it. It's not this, but I think that the kidney fund stack index is a great way of first introducing yourself, and it's pretty comprehensive. But there are other signs and symptoms that TMD patients have. One, pain in the actual TMJ. Arthro means joint, itis means inflammation, arthritis. Who is this Arthur guy? But pain in the TMJ. Pain in the TMJ, arthritis. You also see flattened teeth. You look at x-ray or you look in the mouth, you see flat teeth, you know the person's grinding, they probably have a TMD problem. Exostoses are bone bumps that go outside of the alveolar process. So it's the bone above the teeth. They stick out on right and left side, or the lower or the upper. Tori are on the inside. The same thing, bone growths. Growing out, exo, skeleton, outside skeleton. Exo means out. Osteo means bone. Exostosis, exostosi. These are bone growths out. Tori are bone growths in, right? you could see distortion of bone on an x-ray. Anti means before, gonial means the angle of the jaw, antigonial notching from the masseter. Abfraction is from constant twisting and bending of the teeth, which causes dissolving of the dentin on the end of the gum of these teeth, little notches everywhere. Scalloped tongue. The patient is putting their tongue in between their teeth to hold their teeth apart. They're making their own appliance, for real. And Netter, a very famous physician who drew pictures, he said scalloped tongue is due to hypothyroid disease. And we see scalloped tongue all over the place, right? Lots and lots of people. But you can look at Netter's illustrations under hypothyroidism, and there he's got a scalloped tongue. And so many, I would say at least one in four TMD patients have scalloped tongue, right? We see it everywhere. Reversible means it will come back. Pulpitis, itis means inflammation. Pulp is in the middle of the tooth. So you got tooth pain, but it gets better if you put a soft guard in or you put an appliance in. Irreversible means this patient's killed this tooth. For real. So a lot of times I try to save teeth to see if it's reversible, but it was too late. It died. It needs a root canal or extraction. Linea alba, line. Linea means line, alba means white, a white line, and this is where the patient is chewing on their cheeks. Well, think about it. If they put their tongue between, you get scalloped tongue, but some of them put their cheek between instead of the tongue, and they chew on it, and there's a white line in the mouth on the cheeks, linea alba. Calcified stylohyoid ligament, you see this on panoramic radiographs. It goes from the styloid process, which is just a little inside of the temporomandibular joint, and it is like a little spike nail, a bone, but it's only supposed to be short, but it gets longer and longer and longer right down to the throat. Respiratory allergies, you look at the nasal, you look at the x-ray, the panoramic x-ray, and you see the nasal area is completely blocked up. This gets me. Dentists look at dentistry and teeth. They don't look in the nose because that's not part of their education. But I believe, and the medical profession believes, you should read everything in the x-ray. So I'm going to read the nasal aperture, the nasal area, to make sure that it is, in fact, completely open, black, but very often it's not. EDS is Ehlers-Danlos syndrome, which is a collagen deficiency disorder. We do see maybe 1 out of 20 patients will have a collagen deficiency, and their fingers will bend weird, parts of their body will bend weird because they don't make good collagen. Remember, all the ligaments are made out of collagen. The disc, temporomandibular joint disc, is out of collagen. And get this, bone is formed with collagen. And the next thing is cracked tooth syndrome, where there's just lots of pain and they've cracked their tooth due to constant grinding and hitting. But there's more even than this. But there's lots more things that you see. You will learn as you practice this profession that there are other things, and like polycystic ovarian disease. Oh my God, I just connected the dots on that one. And there are other medical conditions which are, I guess, related that we don't put under signs and symptoms, but they're there, and we go over that later in our course. So some really important things to understand is that many TMD patients, especially ones that are coming in for a consultation, never been in our office before, they just don't know the signs and symptoms of TMD. So they may think ear pain is some sort of brain tumor or something seriously wrong with their ears, and it's not. Or a swallowing problem being, part of a throat dysfunction or throat cancer. These patients are worried about constant problems related to various signs and symptoms. They've gone to other specialists and they've never got answers, and it's really sad because there's no crosstalk among the different professions. But remember, They do not know the signs and symptoms of TMD. So when reviewing the kidney fund stack visual index with a new patient could be extremely, really valuable, because all of a sudden they see all these things and they say, oh my God, I know what I got now. I'm not going to die. I can be helped. And this is it's a relief on some people. We've had patients sit and just cry, and they've gone through so much, through so many years, thinking perhaps no one's ever going to find out what's going wrong with them, and that they're going to have to suffer with these signs and symptoms for the rest of their lives with no help from anyone, right? But the kidney fund stack visual index will help the patient understand that they do in fact have a TMD problem and not a serious brain tumor. There's a lot of relief in finding out what your problem is. It really is. It's like, okay, so this isn't going to kill me, right? It's not uncommon for a patient to begin crying in the dental chair after reviewing the TMD signs and symptoms with you, because the patient's often seen 5 or 10 other doctors who do not know why the patient was suffering. Now, one of the most frustrating things, sad things, nerve-wracking things for me is the assistant will not work with me to find out all of these doctors. Why? Because wouldn't it be a wonderful thing, a blessed thing, if we send a report to these doctors and maybe some information about TMD, and some of them are going to say, oh my God, look at this. I've just learned why many of my patients are suffering. Oh my Lord, now I know. I didn't know before. I was never taught this before. This is crazy. Maybe I should start referring some patients to Dr. Podolsky in the Atlanta TMD Institute. Yes, I'm going to. And now you have achieved really something bigger and better than just this one patient. But I just don't seem to get this. It seems over the past 5 to 10 years, I've never got anyone super concerned, super, competent, that will go back and do this work for me. And sometimes right in front of that assistant, the patient will say these names out loud, and the assistant will not act. And then I have to go see another patient, and it's extremely sad, because you could possibly bless other people, and you choose not to because you're lazy, you don't care, and you say, well, I do care. No, you only, if a husband loves his wife, say, I love my wife, but I beat her regularly. That's not love. You know someone by what they do, not by what they say. So it's extremely important that we get a list of these doctors and send them a report. Let them know what's going on with their patient. When the patient better understands his or her disorder, the patient's also more likely to accept and begin treatment, and we can do what we do. I do what I do. I'm a healer. I heal people. Sometimes I do work miracles. I have made the lame walk. I have. I have actual instances, actual patients who are suffering every day of so-called migraines. I have gotten rid of almost all of them, or all of them. I have done miraculous things. People who were shaking uncontrollably, I have stopped them from shaking. I have done so much that I can't stop. I love doing this because it's so rewarding. Of course, there's a devil in the world. So you're going to probably about 1 out of every, I'm going to say 15 TMD patients is crazy and evil. And that's true. But that's true of mankind, right? No matter where you go, there's going to be someone making trouble. And you'll have some people that make you miserable. And we just have to focus on the good people, the people that give us like inner strength and make us feel worthwhile and give us purpose to help them. And they're appreciative, and it's so good. It's bonding, and I bond with them. So again, teaching these signs and symptoms to the patient makes them say, oh yeah, I do have this and I need to have it taken care of. I mean, what is the monetary worth of if a person's having 15 headaches every month, really incapacitating headaches, and we can get rid of them in money. What is that worth? Like, right? When they're curled up in the bed and they can't move, what is it worth to get rid of those headaches? So you will actually, in fact, by teaching these signs and symptoms, convince them to get treated so that we can function and exist and grow, right? That's very, very important. The unfortunate reality of life is money makes the world go round, and it powers your salary, it powers the payment for rent, it powers the payment for malpractice insurance, telephone, advertising. Geez Louise, all of this is expensive, and we want to help people, and yes, we want to convince them to get treatment because that's what we do, right? We know we're going to get them better, and they don't, but we do. So we want them to get cared for by us. As dentists and healthcare healers, and I say healer, not professional, I'm a healer, we want to help people. So anything that helps patients say yes to needed treatment is a very, very good thing. So I want to say thank you very much for going through these. This is still a work in progress. As we progress, as I get older and see more and more patients, I learn more and more. And of course, there'll probably be an update. It's 2020 right now, and probably things will evolve more and more because TMD is a discovering science. We're finding more and more and more. I'll give you an example. I've always felt that metabolic syndrome was part of TMD because I see it, and I'm going to say 1/3 of all my patients, probably even higher, maybe 40%. And doing the research on a Sunday morning for 4 hours, I was blown away against the wall because I found so many connections between metabolic syndrome, pre-diabetes, and TMD, making it my interest now. It's always been my interest. I suspected it, and I felt it strongly. And when I had people take care of the metabolic syndrome, they got better. So I'm evolving, and I think the knowledge about TMD is going to evolve, and that we're evolving and we're involved in something really, really wonderful and something really, really kind of serious because the head is the most important part of the body, and everything goes around the head. Problems in the head are going to be serious problems to our brains, right? To our psyches, to our souls. So thank you again, and look up some of these muscles, look up some of these conditions, learn, and good luck in your pursuit of helping other people get better.